Thank you very much. Yep, so as you've just heard, the presentation today is on older people's experience of dignity and nutrition, specifically their experiences of support with eating during hospital stays in England. And it's based on a secondary analysis of the adult inpatient survey. It's joint work with Tanya Burkhardt and Ellie Suet-Case. And it was originally funded by an ESRC grant. We've also had some LSE knowledge exchange funds to work with Age UK on impact around some of the findings. And most recently we've had an III small grant to update the analysis and also to extend it in certain ways that I'll be talking about today. So in terms of the objectives, motivation and background to all of this, this piece of work has really come about as a result of broader work that we've done with the Equality and Human Rights Commission to develop an indicator set for monitoring national equality and human rights. So the Commission has a statutory duty to monitor equality and human rights using indicators under the Equality Act 2006, and it does that periodically to Parliament. And we've been involved in developing an indicator set that the Commission uses to monitor inequalities across 10 critical domains, so life, physical security, education, health, we call those capabilities, but they're critical areas of life. And the indicators have been agreed through a national consultation that took place some years ago. So the health domain indicator dashboard includes an indicator on treatment with dignity and respect during hospital stays and an indicator on support with eating during hospital stays. So basically, when those two indicators were agreed, there was some publicly available data that we could use for monitoring purposes, which the Care Quality Commission produced based on the adult inpatient survey. But the pre-existing data publications and also specialist studies in this area were limited in certain respects for our purposes. So big problem was that the annual published data was based on a population average approach. So for the EHRC and also John in his work for the National Equality Panel, we produce data that is disaggregated by the characteristics that are protected and recognised in equality law, and the data didn't allow us to do that, the published data. Partly as a result of that, the position of older people was not separately identified and reported. And also we had a puzzle arising from the various specialist studies that have been done in this area, the more in-depth treatments of this, finding that inpatient experience improves with age. Now, it had already been recognised that there seemed to be an apparent inconsistency between that kind of statistical finding and the growing body of qualitative inspection and public inquiry evidence that was building up in this area. Then I'm just going to run through briefly in a minute. And one explanation for that in the literature is that this is to do with adaptive expectations and gratitude bias, so older people answering questions differently from other groups. They maybe complain less or have lower expectations. But another point that we realised in our early discussions with Age UK is that much of the analysis tended to group the over 65s together and not to separate out an analysis of the oldest of the old, and also not to look at the way being over 80, for example, combines with other risk factors such as disability and gender. And we also had some other problems like the weights that were publicly available weren't suitable for our analysis, and the focus of much of the performance monitoring has been on a deviation from average approach rather than a rights-based or a capability approach, and I'll say something more about that as we go through. So what we've tried to do in this study is to build up an in-depth quantitative evidence base on older people's experiences of dignity and support with eating using the survey. So we've looked at prevalence rates, subgroup variations, relative risks amongst the older population, trends over time. We've done what we can do with this particular survey to try and explain poor treatment, look at the drivers, and we've drawn out implications for public policy, monitoring, regulation, and inspection. So our first report was on using the 2012 survey. We've now managed, with our grant, to update to 2014 and to extend the analysis to examine the effects of hospital-level socio-economic deprivation that we didn't have in our earlier analysis. So the qualitative evidence, people will probably know that media, public policy and political focus on this whole area of older people's treatment in healthcare was moving up the agenda as we were doing this work. So we had a first wave of concerns going back to the mid-2000s. The Joint Committee on Human Rights published a agenda-setting report in 2007, The Human Rights of Older People in Healthcare, that really raised issues around neglect, abuse, lack of dignity and respect, issues of consent and discrimination, malnutrition, dehydration, and lack of support with eating and drinking. We had a report by Age UK in 2010. Both the Patients Association and the Health Service Ombudsman produced publications highlighting a whole range of case studies with major concerns in this area. And the Care Quality Commission launched a targeted programme of dignity and nutrition inspections in 2011 and 2012. Then kind of in parallel with that, we had a whole tsunami of findings associated with the two Francis reviews. So we had the independent inquiry in 2010. So just to read from that, that found that the most basic standards of care were not observed, fundamental rights to dignity were not respected, elderly and vulnerable patients were left unwashed, unfed and without fluids. They were deprived of dignity and respect. Some patients had to relieve themselves in their beds when they were offered no help to get to the bathroom. Some were left in excrement-stained sheets and beds. They had to endure filthy conditions in their wards. There were incidents of callous treatment by ward and staff. Patients who could not eat and drink without help did not receive it, etc., etc. So just in case anyone is concerned that this isn't a problem, I think that kind of sets it out. In 2013, the public inquiry found that there'd been serious systematic failure at mid-staffs. Substandard care had remained undetected, and therefore there'd been regulatory and management failure. And it set out 290 recommendations on how to make things better in the future. The coalition government then mainly accepted those recommendations. We've had policy initiatives since around safety, compassionate care, dignity and nutritional support. We've had the malnutrition task force that Age UK has been involved with, and we've had a series of other reviews highlighting related issues. We've had a regulatory response to the Francis inquiry, so the Care Quality Commission introduced a new inspection model, and I'll be saying something about that later, but it makes better use of some of these statistics that we'll be looking at in advance of inspections. NICE introduced some minimum standards, and we've had new fundamental standards of care introduced, and those include specific standards relating to dignity and respect and to support with individual nutritional needs. So what we've been doing is trying to look at what an analysis of the national available statistical evidence on dignity and support with eating adds to this qualitative evidence, and how can we better use this data to inform ongoing processes of quality improvement. So the data itself, the Adult Inpatient Survey is an annual survey. It covers all NHS acute trusts. It targets 850 continuous discharges from each trust, and patients over 16 are, broadly speaking, eligible for the survey. Questionnaires are sent to home addresses. In 2014, the discharge window was June to August, so it is a summer survey, which may not pick up winter pressures, for example, so that's one issue, that the window is a summer window. In 2014, the sample achieved was 59,083. That's representative, or a bit lower, in fact, than other years, so it's always very big, the data set that arises from this survey, but it is only a response rate of 47%, which is a bit on the low side. It covered 154 trusts in 2014, which is all of the trusts that were eligible. The version of the data set that we've used has been tailored and provided by the Care Quality Commission and the Picker Institute. So it's a special release data set with secure conditions. The data set at the data archive doesn't allow you to identify over 80, those who are over 80 or those who have a disability. So looking at those variables means looking at this securely. And we've also had permission to link in the HES hospital episodes statistics-based information on socioeconomic deprivation, which is what we've done in this expansion, and also to add in some extra information to construct some weights. So the kind of cost of having the access to the secure data has been that we've had to group specialist trusts, which is smaller trusts, so they're in there as a group. And we haven't had permission to use the ethnicity variable within the main analysis. So we can do a breakdown by ethnicity, but not include it in conjunction with other variables. That's something we hope we might get permission to do in the future. So there are a number of data limitations that we are very upfront about and ought to acknowledge. There is always the possibility of coding errors. I've said about the low response rate, the grouping of specialist trusts, ethnicity not being allowed to be used in conjunction with other variables. The socio-economic deprivation indicator wasn't available for specialist trusts, so for that bit of the analysis, the specialist trusts are dropped. There's some limitations of coverage, so the sampling frame doesn't cover people who die. We might be particularly concerned about those people, so that's important. So it's based on live discharges, the sampling frame. Those who are ill or who need support, and we might be particularly concerned about those with Alzheimer's or dementia, might be less likely to fill in the forms. So they might disproportionately not respond to the survey, even though we might be particularly concerned about them. The focus of this study is on the acute sector, but there is patient experience data for other sectors like mental health. We're not talking about it today, and we're not covering private providers in the discussion today. But first and foremost, inpatient experience data is self-reported subjective data. So its strength is that we're learning from service users directly about their experiences as they perceive them. It does have possible weaknesses, and I've mentioned about different groups answering questions differently in a systematic way, and that might be particularly true for particularly subjective questions, and there's the issue of older people's adaptive expectations. And we don't have objective information about context. For example, the quality and quantity of nurses, we're reliant on perceptions data. So when I'm talking later about quality and quantity of nursing staff, for example, that's what people say about the nursing staff. And people have given various suggestions for getting hold of some more objective data on that, on nursing, but we don't have it at the ward level. So this is what the individual experience is and reports that they experience. We make use of some new patient level weights which have their own limitations. They're quite experimental and new. So they're intended to correct for differential non-response and also to make an adjustment for the size of the local inpatient population. So we think they're an improvement in some ways on the standardisation weights which were available through the data set. But they are new and constructed by us, and we think those could be improved in the future. So we focus on two survey questions, which are very related to what we want to look at. So first of all, did you get enough help from staff to eat your meals? And people can say yes always, yes sometimes, no, or I don't need help to eat meals. And overall, did you feel you were treated with dignity and respect while you're in the hospital? And again, they can say yes always, yes sometimes, or no. And, whoops. Sorry. The way we interpret those answers influences our findings. So our findings are based on a particular interpretation of those response options. So if people have said, yes, I always received the help I needed, we're saying that they experienced a satisfactory standard of care. If they say no, I didn't receive the help I needed, we're saying that they experienced a poor standard of care. If they say yes sometimes, it's quite tricky because there's a yes there, but it's sometimes, so it's a qualified yes, sometimes no during a hospital stay, seems to be the interpretation. So we've taken them to be experiencing an inconsistent standard of care. And what I'm going to be talking about is experiences of inconsistent and poor standards of care based on that interpretation. So I'm going to take you through our 10 key findings, and then I'm going to show some graphs that support the findings, but I thought it would be useful to have the findings first. So first of all, we found that there is a widespread and systematic pattern of poor and inconsistent standards relating to these outcomes in England. So we don't think overall the story is one of a couple of outliers or a marginal concern in a particular hospital or a particular ward. There are some concerns in particular hospitals and particular wards, we're not saying there's not, but we think there's a more widespread and general problem than just looking at the outliers would reveal. So secondly, we think that the need for help with eating is also a very general challenge rather than a specialist or marginal concern. So we were quite surprised that 1/3 of respondents need help with eating at some point during their hospital stay, and we think that's equivalent to around 3.8 million people in a year. So that's really a very big demand on hospital staff that we're talking about. We found that more than 1 in 3, 39% of those who need help experience inconsistent or poor standards of help with eating. And our best estimate is that that's equivalent to around 1.5 million people in a year, including around 760,000 who are aged 65 or over. Just under a quarter, 22% of inpatients experienced inconsistent or poor standards of dignity and respect. That's about 2.8 million people, of whom around 1 million are aged 65 or over. Amongst the over 65s, we found that the risks are higher for the over 80s, for women, and for people who experience a limiting, long-standing illness or a disability. We found that there's been remarkably little improvement over time, depressingly, although there are some limited experiences in the most recent improvements in the most recent years, and that might, as a positive note, suggest that some of the new policy initiatives are beginning to feed through and have some impact. In terms of explanations and drivers, from what we can learn from the adult inpatient survey, we found that the quantity and quality of nursing care, so that's perceptions of the quantity of quality nursing care, and also whether there's a choice of food, so something about the food itself, have strong, statistically significant associations with lack of support with eating. And we think that has some public policy implications, so the quantity and quality of nursing and the choice of food can be potentially influenced by public policy. Obviously, the pressures created by disability and age can't be changed by a trust, but relatively speaking, these are policy-sensitive variables. We have 2 lessons for monitoring, inspection and regulation. The first is that the implementation of the new standards, the new fundamental standards of care that I mentioned just now should be monitored based on a minimum threshold approach rather than a deviation from average approach, and I'm going to show you some graphs that explains what that means. And finally, the importance of disaggregation, so undertaking inequalities analysis. The monitors and inspection and regulation bodies should be disaggregating their data more systematically rather than relying on a population averages approach. So, the descriptive findings. In terms of the scale of the problem, we've said it's a big problem and a widespread problem rather than a problem in individual hospitals, and it seems to affect a substantial percentage of the population. So this is the prevalence of poor or inconsistent standards of help with eating. It's expressed as a percentage of those who need help. And you can see overall, within this group who need help, 18% are reporting that they experience poor standards, so that's those strong no's, and 39% are reporting poor or inconsistent standards. So that's the strong nose plus the intermediate category. And that's how we get to our figure of 1.5 million people being affected annually. The age trend that I talked about, that we get improving experiences with age, is reflected up to 80, but you can see that there's this upturn here, and if you look at 5-year age bands, that becomes more pronounced. So it's kind of a U-shape after age 80, in fact, rather than improvement. If you're female, you'll have a higher proportion of females reporting both poor and inconsistent standards than males, and a higher proportion of those with a disability are reporting poor and inconsistent standards. So that's 46% of those with a disability. And then if we look at the prevalence within the older population, those over 80 who have experienced a disability, we're up to nearly 24% of those saying that they didn't receive the help that they needed, and 57% said that they didn't or sometimes didn't receive the help they needed. So reaching very big proportions. And then if we look at those age 80 who are female and who experience a disability, we get to 25% for the strong nose and 61% for the poor or inconsistent standards. So really very substantial proportions, in fact, of that subpopulation reporting a problem. In terms of the consistency of the problem across trusts, this plots, all of the dots are a trust, and these are the estimates of the proportions of poor or inconsistent standards. So this one's poor standards, and this one's poor or inconsistent standards. These are the estimates of the proportions going up here by trust, and the estimates for poor or inconsistent standards here. And so we can see that the range here for poor standards is from 9%, with an average of 18%, going up to 28% and then even 32%. And for poor or inconsistent standards, starting at 20%, an average of 39%, and going up to here 54% and even 63%. So on the one hand, there's clearly an issue for some of these up here, but we feel that the big picture here is actually that what is normal is too high, and there's a general problem for the vast majority of trusts, and that this isn't just a question of the outliers up here and identifying those, but more a general issue of why this whole distribution is so high. And if we just look at the confidence intervals that come with those trust estimates, they are quite wide. So there is a degree of uncertainty around those estimates. But what we can also say is that the trusts are quite undifferentiated. There's a lot of overlapping confidence intervals, which means it's difficult to find statistical significance between the differences. It's difficult to find any that are actually different from each other. So if we look right at the bottom and compare it to right at the top, we have a couple of differences. But if we compare with the average trust, there's very few differences. So what I'll be saying later is if you adopt a deviation from average approach to monitoring and you look at the difference with the average, you only find a problem in relatively few trusts. So the persistence of the problem is trends over time. So what we find over time is that really there's been not very much real change or improvement. So this is Help with Eating again, and this goes back to 2005. So for poor standards, we find this is very slightly different percentages because it's not weighted. The other data used are weighted percentages, and our trend data set is unweighted. So we have an average here of 17, 2014, and you see that the unweighted average was 17 in 2005, so no change there. For the poor or inconsistent standards, there has been a bit of an improvement. So a 2 percentage point decline. So that is the positive story. Here, it doesn't look like a huge change, I think intuitively. It is a statistically significant one. But if we're to find a positive story here, that's it. There has been a bit of an improvement in the most recent years in people's responses to these questions. For dignity and respect, it's the same picture. So here we have the strong no's. This is a percentage of the whole sample now. So flatlining for the strong no's and a 2 percentage point decline. These declines here, if we look at what the CQC published data, we think that that improvement has also been reflected in 2015. We don't have data to say what's happening at the moment with the huge pressures in 2016 or indeed 2017. But as of 2015, there is a bit more of an improvement there. So now I'm going on to our analysis of the drivers of lack of help with eating. So this is our logistic regression analysis. So the dependent variable is a binary one, whether people received enough help with eating from staff. Our focus for this exercise is the strong no's. So those who said very clearly, no, I didn't get enough help, they're our ones. And we've captured the distinction between the ones, the very strong no responses, versus everybody else. So the zeros are either people who didn't need help or people who did need help but received it. So we've taken the full sample as our main model because we think it's in line with a capability or rights-based approach. But we have, obviously, there's conditional nature of whether people receive the help that they need within this. So we've also produced restricted versions of the regression analysis and looked at the findings from that as well, which are slightly different, and I'll say something about that. So, the independent variables, we've looked at individual characteristics, so age, disability, gender, and proxy responses. So sometimes the forms are filled in not by the respondent themselves, but by a friend or family, or with the help of a friend or family, or with the help of a professional. So we've controlled for that. We've controlled for individual pathway or journey through the hospital, so whether it matters your route of admission, whether you stayed in a critical care unit, the number of wards you stayed in, your length of stay, whether you had an operation. We've included information on nursing and food services. This is the subjective information that I said. So this is perceptions of the adequacy of the number of nurses and perceptions of the quality of nurses and whether there was a choice of food. So that's a slightly more objective question. We've made use of the 3-digit hospital code information that's available, and we've controlled for hospital level socioeconomic deprivation. So let me just tell you how we've constructed that. So the socioeconomic deprivation trust level information is based on an indicator published by NHS England. So the starting point for this indicator is a spell within a hospital. That's to be distinguished from an admission, so you're admitted once, unless you're readmitted, but you can have multiple spells. A spell is a period under a consultant. Within the hospital episodes data set, there's information on spells and the person's postcode. So the postcode is then given an IMD rank, an individual rank, or it's put into IMD, it's linked to IMD quintile information. That IMD quintile and spell information is then used by NHS England to construct an indicator, and that is called the IMD quintile rank by spell. So it gives the percentage of spells which fall under each deprivation quintile. So, for example, the IMD quintile 1 spell rate, which is what we have used, gives the proportion of spells that are from the most deprived IMD quintile over the total spells, total number of spells for each trust. So it's a bit complicated, but hopefully that's clear. Now, we have a number of limitations of the regression analysis. So I mentioned we couldn't put ethnic group into here. The deprivation information isn't available for specialist trusts, so where we've used that, we've had to omit the specialist trusts. The nursing and food data is subjective, so that it's obviously quite complex to interpret that. Length of stay, there's possibility of some causal loops going on, that long length of stay is predicting poor care, but then poor care might lead to a longer length of stay. So those are some of the issues that have arisen in this modelling, and to deal with that, we've tried to do quite a lot, particularly introduce the variables in very slowly and carefully and look at their effects. But we have got multiple specifications of this model, and we've got restricted versions and unrestricted versions. We have our main ones that focus on the strong nose, but we've also sensitivity tested to the intermediate responses. We have some with an interaction variable that looks more closely at the way disability and older age interact. And I'm reporting on a multi-level model, but we've also produced some single-level models. So just to map that out for anyone who's interested in that kind of thing, this is our modelling strategy. So for our multi-level models, we introduce inpatient characteristics, then deprivation, pathway information, then the perceptions data. That's all on the full sample. Then we produce one that's restricted to respondents who need help with eating. Then we have two versions of those with an interaction between disability and age. And then the fixed effects models, one is simply a sensitivity test to see if we get any differences if we use a single level model controlling for clustering effects. And then we also use the fixed effect model to look at the story for individual trust effects. So we build it up starting by just looking at individual trusts, and then we add in inpatient characteristics, inpatient pathway, and the other independent variables to see what we can say about individual trust effects. And for that model, deprivation has been dropped, which is a trust level variable. So what did we find? This is the factors associated with poor standards of help with eating based on the full sample and its odds ratios. So odds ratios, as some of you will know, are a measure of association between a predictor variable and an outcome variable, and an odds ratio of 1 for a subgroup like females means that there's no difference in the odds of poor care compared to a reference group, in this case males, for example, and an odds ratio of greater than 1 means there's greater odds for that subgroup compared to the reference group. Odds ratio of less than 1 is lower odds for the subgroup compared to the reference group. And the asterisk is a statistical significance. So what we can say from here is that being female, even after we've controlled for everything else that we've put into this model, does predict poor care, so a higher odds for females and a higher odds for those who experience a disability compared to those with no disability and compared to males. The age story is kind of similar to the descriptive analysis as well. So we do get these reduced odds for these subgroups compared to the reference group, a younger reference group, but we do also have a sign of a bit of an upturn amongst the over 80s. Proxy turns out to be important, so where a friend or relative has filled in the form, or where a friend or relative has helped to fill in the form or given support, the answers are more negative. So they are important in predicting, poor experience being reported compared to where just the person filled in the form themselves. So families and friends may have more negative perceptions of what's going on sometimes than the person themselves. In hospital level deprivation, so this is colour coded. Purple is the inpatient characteristics, Blue is hospital level deprivation. Grey is the information about inpatient pathway. And green is the perceptions data on the quality and quantity of nursing and food services. So blue, hospital level deprivation. We've gone to an awful lot of trouble to include this variable, but the complete absence of asterisks is there will tell you that we don't have a statistically significant finding. In the descriptive data, we think that we also don't get much of a socioeconomic gradient, and that might be because although disability is more concentrated in the more deprived areas, actually older age is less concentrated in the more deprived areas. So those two things might be going in opposite directions, and certainly by the time we've controlled for compositional effects, there isn't a significant effect, although, for example, in the most deprived group of trusts there is a little bit of an increase in the odds compared to this least deprived setup here. Inpatient pathway, on the other hand, is important. Length of stay seems to be important. So those that are staying 1 to 2 weeks, 2 weeks to a month, 2 weeks to a month in particular, have a higher odds compared to those who only stay for between a day and a week. Once we've controlled for that, the number of wards descriptively is important, but once we've controlled for length of stay, the number of wards is becoming insignificant. That's quite an important finding, I think. And then admission route and staying in a critical care unit both made a difference, but having an operation didn't. And then we get to the perceptions data, which perhaps not surprisingly is having very strong effect on people's reported experiences of help with eating. So where they felt there were only sometimes enough nurses, or there were rarely or never enough nurses, compared to where people felt there were always enough nurses, we get higher odds of poor support with eating. Same with perceptions of poor quality nursing, where people weren't happy with the overall quality of nursing. Their reported experiences were likely to be worse. Interestingly, where there was no choice of food, this is also having an important effect, and that's with Age UK, one of the policy areas that we've been particularly trying to pick up on and see what it is about food delivery that can improve people's experiences. So that's one of the more policy relevant and sensitive findings. So in terms of our alternative models, how do these results that I've just shown you differ from these other specifications? So under the restricted model, the different elements of patient pathway become non-significant. So really that's to do with selection effects, and they're driving perhaps people who need help rather than whether they actually receive the help. The interaction models show us that the effects of age are moderated by disability, as we've seen in the descriptive data. So disability increases the probability of experiences of poor care within each age group, and that moderating effect gets stronger with age, so it's particularly pronounced amongst the over 80s. The fixed effects models, the sensitivity testing, I'm happy to report no important differences in our estimates or our standard errors when we did a one-level version of the model. The full model that we developed to look at trust effects, we found that after we've controlled for everything else, 5 trusts could be said to have independent effects, so an increased odds compared to the average trust. That's an interesting finding, and it's a small number of trusts compared to the average. And it really takes me back to that point I was making, is should we be trying to see whether trusts are different from the average when we monitor this, or should we be looking at the more general nature of the distribution? One starting point for thinking about this question is the CQC inspection methodology, and following the France's recommendations, the CQC adopted a new intelligent monitoring inspection model. I mentioned this at the beginning. So what they aim to do is to evaluate patterns and risks prior to inspection using a basket of 150 indicators. And I'm very pleased to report that the AIS data on dignity and nutrition is included within that basket. So that was an important development from our point of view. It's very positive that that's been included. They then evaluate trust performance based on a deviation from mean approach. So this is looking at this question precisely, which trusts are different from the average or the normal. And a very small number of trusts are identified as being as elevated risk or at risk. And there's also some other things done, like there's a scoring system that they use. They don't just use this data, and they standardise the data, and there's some various corrections and adjustments that are made. And that approach very much builds on academic literature on how to identify poor or unusual performers from a distribution. But another option that is discussed in this literature is a minimum threshold approach, where we take a minimum level and we look at performance compared to that minimum level. And we think that's much more in line with the idea of basic rights or a capability, and the NHS constitution recognising rights to dignity, and the fundamental standards that I mentioned at the beginning, which includes these new standards relating to dignity and to support with eating. So the proposition is that for monitoring the implementation of those standards, we think that judgments about their implementation should be very much based on a minimum threshold approach rather than a deviation from average approach. So just to explain that graphically, or to give you a visual that makes this point, this is a funnel plot, which is widely used in public health for looking at comparisons of institutional performance, and it's a bit like a scatter plot. So all of the dots are trusts, and this is the percentage with strong no's by trust, reporting that they didn't receive enough help with eating, and this is the sample size. The precision of these estimates, the theory is that the precision of these estimates improves the sample size, and so you get what's called control limits, which are these dashed lines, which are a bit like confidence intervals. So the purpose of the control limits is to tell you what's different from the average, what's different from the normal. And within the control limits, we can say that all of these trusts just exhibit normal variation to kind of noise. We'd expect some variation, there's got sampling error, and they all get the green light. So they're not different from normal. At a slightly higher level of confidence, these ones here are above this first control limit. So this handful here, we'd say they're behaving unusually compared to the normal. Put them on alert, which is an amber warning in kind of traffic light systems that are used. And then at a higher level of confidence, we get a red light, an alarm, so we're really confident that these are different from the normal trust, the normal distribution, and we're concerned about them. And likewise, we can identify trusts that we think are behaving particularly favourably, and perhaps learn from that good practice. So this funnel plot, this red line here is the average. So we've said what is the deviation from the mean, what is the deviation from average. So that's a deviation from average methodology. But an alternative is, instead of taking the red line, the average as the target, is to explicitly come up with a target. Now, we might argue about what that target should be, particularly in relation to subjective data. So we might maybe expect some people to say they weren't treated with dignity and respect, or it's okay that some people say that they didn't receive the help that they needed with eating, and we might say it's okay for 1% of people to say that, or 5%, or 10%. We'd need to explicitly come up with a target and agree it. But if we did set the target at 1%, you can see that we would be alarmed for all of our trusts. That is a quite demanding target, and we might want something more like 5% now. But even if we chose 5%, 6%, 7%, we're going to be alarmed about a large number of our trusts and the proportion in them reporting that they didn't receive enough help with eating. So that's it, really. I seem to have rushed through this ahead of time, so plenty of time for questions. In terms of the conclusions, we think that there's a widespread and general problem, as we've argued, for affecting a substantial proportion of the population of inpatients nationally within the vast majority of trusts. So we're not seeing this as an isolated concern or a question of a couple of outliers, although those that are identified through the inspection process as outliers, of course, that is an important finding, and it is important to look at what's going on in those trusts. We found that the prevalence of inconsistent and poor standards of care are highest amongst the oldest of the old, and within that for individuals who experience a disability and for women, and the highest proportion overall is in women over 80 who experience a disability. In terms of policy implications, nursing services and food services stand out as particularly policy-sensitive variables. So the policy implications are that we need to look at those variables. And in terms of food services, we've worked with Age UK, and we've convened a series of workshops which bring together NHS staff, canteen workers, dietitians, nutritionists, nursing staff, to talk about food services and to identify good practice and to try and learn from that good practice, and around some of the initiatives that are going on, the dignity and the support with eating initiatives that are going on nationally. In terms of the lessons for monitoring, inspection and regulation, we're arguing that the implementation of the new fundamental standards of care should be monitored using a minimum threshold approach, not a deviation from average approach. And we're arguing that monitoring should systematically be disaggregated, so this data, when it's produced, should undertake inequalities analysis, and the regulators and inspectors should be doing that. So we shouldn't be looking at population averages, but undertaking inequalities analysis. And when it comes to the over 65s in particular, the position of the oldest of the old, the over 80s, should be identified separately. That's it. Thank you.